Hello, my name is Gwen Driscoll. I'm the Director of Communications here at the UCLA Center for Health Policy Research. As December is a short month for us, today's seminar will be the last in our 2017 series. But stay tuned in 2018 for a fascinating, comprehensive look at mental health care for older adults in California. Specifically, by the age of 75, close to half of all Americans will have experienced a diagnosable mental health disorder. Yet less than a third of older adults in need of mental health services receive appropriate care. In 2004, the state passed the Mental Health Services Act, which aimed to transform the delivery of public mental health from predominantly providing crisis care to consumer wellness, recovery, and resilience model. Included in this is an older adult system of care that is supposed to provide mental health services to California's seniors. How effective has this system been? What promising programs and innovative strategies have counties field tested? In this January 25th seminar, so save the date, Center Faculty Associate Janet Frank and Center Researcher Catherine Keatsman will discuss the UCLA Center for Health Policy Research's extensive evaluation of the state mental health outreach to older Californians, and they'll make recommendations on how to improve service delivery, workforce training, data collection, and much more. So please join us in person or by live streaming webinar on Thursday, January 25th at noon. Okay. As for today's seminars, we are recording it as always, and it will be placed on our website at the address you see at the top of our screen. If you're watching online and you'd like copies of today's slides, please email me at gdriscoll@ucla.edu. That's the center factoid. Please also note we'll have a brief question and answer period at the end of today's seminar that I will moderate. Okay. Now, before we introduce today's speakers, I want to make a brief clarification, because if you are an avid reader of health policy news, and I know you are, that's the center's free monthly e-newsletter, you will notice that today's edition features both this seminar and another study on a separate but seemingly related topic. Specifically today, the center published a review of 3 programs, 2 local and 1 national, also aimed at preventing chronic conditions. As that publication, as well as today's seminar, show, the center's many strengths include the ability to evaluate large, complex health interventions and programs, especially in our specialty areas, such as chronic conditions, diabetes, obesity, as well as health insurance, health economics, and health disparities. But these are 2 separate products. As for the topic of today's seminar, which is LA's Nutrition Education and Obesity Prevention Program, it will shortly be followed by a comprehensive report on the entire evaluation. So this is a sneak peek at those findings, and stay tuned for the report. All right, what is LA's Nutrition Education and Obesity Prevention Program, or NEOP, as we call it? Center researchers Susan Babey and Xiao Chen are here with us to describe this complex effort to stem obesity and reduce chronic conditions in vulnerable areas of Los Angeles, and to do so in places where people live, learn, work, play, pray, and shop. Using a predictive model, the team will discuss what the likely long-term effect of these programs may be on LA's residents. Sue is a senior center researcher, co-director of our chronic disease program, whose work on the link between obesity and sugar-sweetened beverages has been widely cited in efforts to impose soda taxes and other protective measures, and she's also done extensive research on physical activity, retail food environments, etc. Xiao is the Associate Director of the Center's Health Economics and Evaluation Research Program. Her expertise is in statistical programming, data management, and statistical modeling. And with Sue, she was part of a team of center researchers that scientifically examined what has been done and what the effect might be to stem the obesity crisis in Los Angeles. So please welcome our speakers.
Okay, good afternoon, everyone. Good to see all of you here in the room and everyone online as well. As Gwen mentioned, I'm recovering from a bit of a cold, so I apologize in advance if I cough during my presentation Um, I'm also sucking on a cough drop as I speak, which is generally a no-no, but a good precaution under the circumstances. So before I start talking about the evaluation we did, I wanted to acknowledge some folks who were crucial to the work that we're going to be talking about today, and that's going to be published in the forthcoming report that Gwen mentioned. So this project was truly a group effort, and there were several folks at UCLA who were part of the team, including myself and Xiao, Christopher Lee, who's here in the room, Yingying Meng, who's also here in the room, Jerry Kaminsky and Nadi Parat, who are not here in the room, and Mei Wang, who is here in the room. In addition to our colleagues at UCLA, we had some colleagues at the Los Angeles County Department of Public Health who provided some extremely valuable information, data, and guidance for this project. So thank you to Tony Kuo, Jack Thompson, and Kate Sutton. And finally, this work was funded by the Los Angeles County Department of Public Health. Okay, so a quick overview of what of the presentation today. So as Gwen said, we're going to be talking about an evaluation that we conducted of an obesity prevention program in Los Angeles County. I'll start out by providing some context for this work by briefly discussing obesity in the United States, California, and Los Angeles County. Next, I will describe the Nutrition Education Obesity Prevention Program, or NEOP as we call it. That was the focus of this evaluation. Then we'll present some of our main findings of the evaluation. Then I will turn things over to Xiao, who will provide an overview of how we conducted the evaluation. And then finally, we'll conclude by discussing some of the challenges and the conclusions and implications of the work. So, many of you are probably familiar with the health risks associated with obesity, but just so we're all on the same page, obesity has been found to increase the risk of type 2 diabetes, heart disease, and stroke, as well as some cancers. The CDC estimated in 2008 dollars that the annual medical costs of obesity in the US are $147 billion, so it's quite a costly condition. And finally, according to recent data from 2013-14 from the National Health and Nutrition Examination Survey, which actually measures adults' height and weight, about 38% of adults in the United States are obese. Now, this chart shows the prevalence of obesity between 2001 and 2013 and 14 in California, which is represented by the dashed red line, and Los Angeles County, which is represented by the blue line. Now you can see that they're almost right on top of each other. So the rates in both California statewide and in Los Angeles County are very similar. But in both places, obesity has increased from about 20% in 2001 to around 26% among adults, I should say, in 2013-14. So locally, we've been experiencing increasing rates of obesity. So in response to this obesity epidemic and its impact on population health and healthcare costs, the Los Angeles County Department of Public Health has supported the Nutrition Education Obesity Prevention Program, or NEOP. Through NEOP, the Department of Public Health in LA funds local partners to implement programs that promote healthy eating, active living, and healthy and safe environments. NEOP programs target people who are eligible for the Supplemental Nutrition Assistance Program, or SNAP, which is formerly known as food stamps, and provides assistance for low-income people to purchase food. The NEOP program involves traditional nutrition education services, such as classes about selecting healthy food options or preparing food in a healthy manner, as well as implementing a series of what they refer to as policy, system, and environmental change strategies. And these are strategies that are intended to create environments that support healthy behaviors. Okay. So this evaluation focused on 5 of the NEOP intervention strategies that have been implemented in Los Angeles County. One of them was nutrition education, so the more traditional classes educating people about healthy food choices and preparation and that sort of thing. Along with 4 of those PSE or policy, system, and environmental change strategies: farmers markets, community gardens, healthy retail, and healthy food and beverage standards. In the next few slides, I'm going to go over the NEOP strategy for each intervention and highlight a little bit about what we know from the literature regarding these interventions' relationship to health behaviors. So in terms of nutrition education, LADPH partners with schools, faith-based organizations, community groups, and grocery stores to deliver evidence-based programming designed to help participants make healthy food and physical activity choices. Programs include class-based nutrition education regarding healthy food options, so things like reducing sodium or sugar consumption, eating more vegetables and fruits, reading nutrition labels, food preparation, as well as cooking demonstrations, information about what people can do to get more physical activity, and including some nutrition education programs that actually include a physical activity component as part of the class. Now, evidence suggests that class-based nutrition education can be a cost-effective means of increasing consumption of fresh fruits and vegetables. And the research also indicates that these types of community-based education interventions can be effective among low-income populations, which is important for this work because it targets SNAP-eligible populations, which are low-income. So the NEOP farmers market interventions focus on 3 strategies: promoting acceptance of EBT, which is electronic benefit transfer for SNAP recipients. So this allows SNAP recipients to use basically what is similar to a debit card at a farmer's market to purchase fruits and vegetables with their SNAP benefits, as well as using WIC coupons. The second strategy is offering healthy food incentives. This includes things like a market match, which helps to make healthy produce more affordable for low-income populations. And then the third strategy is to establish new certified farmers markets or new produce stands in existing markets. And so all of these strategies really have the overarching goal of increasing access to fruits and vegetables in areas where people may have limited access. Now, what do we know about farmers markets? Well, a lot, but relative to this, relevant to this evaluation, there is research suggesting that farmers markets do increase access to fresh produce. There's also evidence that farmers markets are associated with increased purchase as well as consumption of fruits and vegetables, although this research is not entirely consistent, not surprisingly. And lastly, we also know that participating in incentive programs that defray the costs of produce are also associated with increased consumption of fruits and vegetables. And so that would be programs like those market matches that I referred to just a minute ago. Okay, so in terms of healthy retail, it turns out that most people who shop at corner stores purchase beverages and snacks, such as chips and candy, and that these items are readily available in most small markets. So the NEOP Healthy Retail Intervention focuses on increasing the availability of healthy foods in these smaller neighborhood markets. And this process is sometimes referred to as corner store makeovers. The strategy also involves introducing new marketing and signage in stores in underserved areas intended to promote healthier options such as fresh fruit instead of candy or water instead of sugar-sweetened beverages. Now, this is a newer intervention, and there's limited research, particularly on the impact of these kinds of interventions over the long term. But there is some evidence suggesting that corner store makeovers do lead to increased sales of healthy food items. And there's also research that generally suggests that greater availability of produce in small neighborhood stores is associated with more consumption of fruits and vegetables. And lastly, there is research suggesting that in-store marketing strategies around the availability, the price, and the placement or promotion of healthy food items can increase the consumption of these healthy food items. I should say increase the purchase of these items as well as the consumption. Okay, so the NEOP Community Garden strategy focuses on identifying and providing opportunities to develop and sustain edible gardens where people grow plants for food in schools and communities. Now, again, there's limited research evaluating the impact of this kind of intervention, particularly over the long term. But there are a few studies that suggest that community gardens may impact fruit and vegetable consumption, including research suggesting that people who participate in a community garden eat more fruits and vegetables, as well as one study that actually showed this among low-income Californians, which is particularly relevant to the current population of this evaluation. The NEOP strategy for healthy food and beverage standards focuses on promoting healthy standards for foods and beverages provided within LA County Department facilities, public housing units, city parks and recreational facilities, and vending machines. Now, there's been a fair amount of research examining the impact of healthy food and beverage standards in the school setting. And this research generally suggests that establishing standards is associated with greater availability of healthy food options and better dietary behaviors. There's also evidence that healthy food procurement policies in healthcare settings and government organizations are generally effective at increasing availability of healthy food options and decreasing availability of unhealthy options. So these NEOP interventions, the 5 that are the focus of this evaluation, as well as others that I didn't discuss that are also part of NEOP but were not part of this evaluation, target people eligible for SNAP benefits. This chart displays the percent of adults reporting that they receive SNAP benefits, which is the blue section of the bars, along with the percent of adults estimated to be eligible for SNAP benefits but not currently receiving those benefits, which is the red part of those bars, in Los Angeles County and each of its 8 service planning areas or SPAs. Eligibility was estimated based on being enrolled in Medi-Cal or having incomes below 185% of the poverty level. Now, this doesn't fully capture all of the requirements to be eligible for SNAP, but it was the best we could approximate with the available data. Now, what I'd like you to notice about this chart is that SPA 4 and SPA 6 have the highest proportions of adults who are eligible for or receiving SNAP benefits. And because of the high concentration of SNAP-eligible individuals in these 2 SPAs, 4 and 6, a large number of the NEOP interventions were implemented in these areas. And these 2 SPAs are the focus of our evaluation. So one of the goals of NEOP is obesity prevention, and this chart displays the rates of overweight and obesity in Los Angeles County and its service planning areas, or SPAs. SPA 6, which is generally the South LA area, has the highest rates of both obesity and overweight, about 40% overweight and 40% obese. So considerably higher than the other service planning areas. Most of the other service planning areas are similar, with rates of overweight and obesity around 60%, except for SPA 5, which is West Los Angeles, which has the lowest rates of overweight and obesity in the county. So the first part of our NEOP evaluation involved looking at program data that was provided to us by the LA County Department of Public Health to assess indicators of progress in SPAs 4 and 6. And we found evidence of considerable progress in implementing the NEOP strategies in these two SPAs. So direct nutrition education programs were provided at 108 sites in these two SPAs. 7 farmers markets were implementing NEOP strategies, including accepting use of EBT, incentive programs, and establishment of 1 new market within these two SPAs. Healthy retail interventions to increase healthy food options were implemented in 18 small corner stores. 17 community gardens were developed at faith-based organizations and affordable housing sites in these two SPAs, and healthy food and beverage standards were established at 23 sites, including faith-based organizations and local government organizations. Now, the rest of the results that I'm going to be presenting are based on our simulation models that were developed by our team. And briefly, we used agent-based modeling to estimate and project the impact of these 5 intervention strategies on obesity over a 25-year period from 2015 to 2040. Xiao is going to go into more detail about how we did that after I present these results. So in our models, nutrition education programs were classified into 5 groups based on whether they were direct, so an actual class that people attended, or indirect, which refers to strategies like using posters or distributing flyers at health events. And among the direct programs, they were further classified into whether it was a series of classes or a single class, and whether the class included information about nutrition or information about physical activity. And so that's why there was more than 5 types of interventions displayed on this chart. Because we reasoned that these different types of nutrition education classes would have very different impact on health behaviors. Now, these exposure rates, these estimated exposure rates, are calculated from the model output based on the number of individuals who were estimated to participate in each intervention. In SPA 4, we estimated that direct nutrition education programs focused on exercise had the highest estimated average exposure rates, and farmers markets and gardens had the lowest estimated exposure rates. In SPA 6, the pattern of exposure rates was somewhat different from SPA 4. So in SPA 6, healthy retail had the highest exposure rate, close to 20%. And direct nutrition education classes, which were focusing on exercise, which were high in SPA 4 in terms of exposure, had relatively low exposure rates here of less than 5%. So our models also estimated weight change for individuals participating in each type of intervention. And this table displays the average annual changes in weight for each intervention. So this would be the average amount of weight that people lost each year over that 25-year period. from participating in each of the different interventions. Did I say that right, Christopher? Good. Okay. In both spas, the largest average annual weight changes were associated with direct nutrition education classes focused specifically on nutrition. So over the course of 25 years simulated in our models, individuals participating in direct nutrition education classes lost an average of 0.12 kilograms per year in the case of a series of nutrition classes, or 0.08 or 0.09 kilograms per year if it was a single class focused on nutrition education. But when you're looking at these, keep in mind also that in our simulation models, all of the interventions displayed are operating at the same time. So these models account for the presence of the presence and the impact of the other interventions occurring at the same time. Now, among the PSE or policy system and environmental change strategies in each spa, farmers markets and community gardens were associated with greater changes in weight than interventions targeting healthy retail and food and beverage standards. So in both spas, individuals participating in these interventions were estimated to lose an average of about 0.06 or 0.07 kilograms per year. So what does this mean in terms of the obesity rates in these two areas over 25 years? So in our models, we estimated changes in weight and used these to calculate the prevalence of obesity in each of the two spas between 2015 and 2040. These two graphs actually compare two scenarios simulated in our models. One without any of the NEOP interventions operating in spas 4 and 6. These are represented by the red bars. And a scenario in which the NEOP interventions are operating. This is the blue bars. Now, what I'd like you to notice about these two graphs is that in both cases, the rates of obesity do continue to increase over time, even with the interventions operating. But importantly, in the scenario in which the NEOP interventions are implemented, the obesity rates don't increase as much. So we are gaining something from the presence of these interventions. Now, focusing on the final year of our model results, 2040, we estimate the prevalence of obesity in 2040 in SPA 4 and SPA 6 is lower in the simulated intervention group, again the blue bars, than in the simulated control group. In SPA 4, the estimated prevalence of obesity in 2040 is 50% in the control scenario compared to 45% in the scenario with the NEOP interventions. And in SPA 6, the estimated prevalence is 58% in the control scenario compared to 54% in the scenario with the NEOP interventions. So at this point, I would like to turn things over to Xiao to tell you a little bit more about how we conducted this evaluation and arrived at these estimated results.
Thank you, Sue. I need to learn the technology first. See what happens. So now we are getting to something more technical, more abstract in the sense. So not many numbers, but behind the scene is what we're talking about. So when we got this project, we could choose approach. So either regression approach or simulation approach. And I want to just emphasize a little bit why regression approach in this case doesn't work really well. Regression approach depends on existing data. When you evaluate the policy change, the data usually is not readily available. For instance, before ACA, you cannot have a data pretending ACA exists, right? So same thing here. So some of the things exist, some of the things may not exist long enough. We don't have a world without the farmers market with the farmers market. So these data are not readily available. Even the data sometimes is available, such as CHIS, not all the relationships, not all the variables actually exist. So it's not to say also the third factor is that usually we don't have longitudinal data. And this is what we want to estimate is the long-term effect, what happens to people year after year, right? So based on that, we basically say the regression approach is not going to be the best approach for this project. Then what are the other approaches? So one very popular and kind of gaining as we speak is the simulation approach. Instead of using the real data, you simulate the relationship or even the individuals. Then you impose the hypothesis that you have either from your research or from your own hypothesis to the structure, then let it run over time. So that's essentially what we take this approach. So we do the simulation approach, and in our specific case, we also we use the agent-based simulation. In there, we have individuals as agent, and agent can interact with each other and take feed in and feedback in the model. So it's a specific type of a simulation approach. In this approach, we basically have our rules, which are basically hypotheses and the relationship that we already know, translate into rules. So for instance, what's the likelihood of someone participating in a intervention? Okay, so how do you define that likelihood? And that likelihood is a function of how far away this person is from that intervention location. Let's say a church has nutrition education, but I live very far, then the likelihood of me going there is smaller than someone live close. Or do I have a coworker who is there, and then I may get similar information from there, so the likelihood will go up. So you can consider a lot of these scenarios and build your rules, right? So then that's part of the model. So building the rules to reflect what we believe the real world is operating, and you can change the rules, when you see, oh, this doesn't work that way. So that's the construct you can build, and you can build relationship among these constructs. It also gives us a chance to synthesize different level of information. So for instance, you could have just that's individual level information. You could have program data directly from LA County about participation rate, what's going on currently with these programs. You also have literature review, research that have done before about specific event, interventions. So all these things could be combined into this model. So that's the benefit of doing this type of model. So the first thing we did is we synthesized data. So some of the simulation, if you are at a higher level, you don't even have to make up individuals. In this case, we made up individuals based on CHIS data. CHIS data has a lot of benefit, and I think we're really grateful to have CHIS data for this research because it provides individuals of all LA, of all California actually, and we basically subset to LA data, and then further we change the weight scheme to reflect each spa that we investigate. So that's one thing. The other thing is CHIS provide the information such as BMI, people weight and height. So we actually know, their starting point, their weight and height. So we have a starting point. We also have variables such as fruit consumption, soda consumption, how much you walk to a place, so these physical activities. So without these variables, we would have to simulate, we would have to make more assumptions. So it's good that we have these variables readily available. So then we can have our individuals built that way. Because most of the interventions are distance-based, or location-based, sorry, not distance-based, location-based. Farmers market doesn't move, so they are fixed. We have to use the distance as one of the factors. In order to be able to use distance, we have to geocode everybody. And chess data doesn't really, especially PubChess data, doesn't give you that geocode. So what we did is we used census tract block population. So each census tract block is fairly small. So it has a population, say, okay, this census tract block has 5 people live there. The census tract block has 100 people. Based on that, we assign each person a location, a geocode, based on that census population density. So you can see that this has assumption in there already, right? So we don't have the specific information about that census tract block has the percent of Y, the percent, we don't have that information. We just have the percent, not the percent, the number of people living there. We don't have a specific type of people live there. So that's assumption we're making already. So there are a whole bunch of assumptions going there. Once you have data ready, what we did is we need to, this is actually a very iterative process. It's not like data is ready, here's our framework, boom, that's, so this is a very iterative process. So we formulate our causal framework. What drives what, right? So we have intervention. So our basic idea is intervention would change people's behavior, not directly change the weight, change people's behavior, and people's behavior would change their weight. So there are more details, how behavior change weight, how the physiological, different people have. So we are not zooming in that much. So we just basically say intervention change behavior, behavior change weight. So this is our basically building block. Okay, so you can see that each building block can be further zoomed in, and you add more information, add more activities, more assumptions, more kind of a causal path in there. But our goal is to estimate at a population level whether the intervention works or not. So we can kind of zoom out a little bit. The model allows us to add more components to zoom in, but right now we don't have all the very detailed physiological what's going on. So that's beyond this evaluation. So once we have that framework, which you will see in next slide, we can start to implement each block and then put them together. The good thing about simulation is that because it's simulation, so you actually you think of this as a black box. In the black box, you put people in and they come out, and you have 2 states. One is what if without intervention? So that's the counterfactual part versus with intervention. So each person goes into the box, comes out with 2 different states. If I were in the intervention, I would have my weight, or not intervention, have another weight. And then you eventually, that's why we have the chart you see earlier. Okay, so far so good. I'm going very slowly. So here is the very general basic framework I talk about. So each person goes through intervention or not, and then in the intervention, whether the intervention is farmers market or nutrition education, whatever, some of these interventions will change the behavior in terms of fruit, vegetable consumption. Some will change physical activity. The effect on these things are different. And then all these behavior change will trigger the weight change. So that's the very simplified framework. So I mentioned a little bit of the effect of, so one of the good thing about agent-based model, of actually one of the big features of agent-based model, is that we can model the interactions of agents. In here, our agents are individuals. You and me, we live in here, and we're co-workers, and you tell me here there is a great exercise class you might want to go, and that's the interaction of agents. So we also build on top of these individuals 2 social networks. One is the family social network, family network, versus co-worker network. So they have different size on average and different type of impact. So you can see this, this is kind of illustration. And the distance to a intervention place, these are all part of the model in there. Oh, it's really fast, slow. So we used a software called Analogic. It's a very powerful software, but it's also very complicated in the sense that it does so many things, and behind the scene it's written in Java. So you can actually program in Java, but the interaction of your programming versus the user interface is not always very easy to handle. But it gave you a lot of the tools. So for instance, it gave you a chance to do the presentation of what you think you're doing. So for instance, we have farmers market here. Farmers market, you might go to farmers market, you might visit farmers market, but you may not buy anything. So there's a different path. So you have a probability to go into farmers market. After that, you have some probability to purchase something good. And then after that, you could add another probability you actually consume. Then so you have all these different paths going on. So this is what Analogic can provide. You can visualize your framework. So each individual can go through different intervention. So each person there is a probability going through each one. They don't have to go through each one. They have different probability. The probability comes from research and also comes from program data. So for instance, in SPA 4, we see lower rate of farmers market exposure, right, than SPA 6. And these are the things that not we invented from the model. Much of the information comes from the program they observe in the field. How many people are going there? How many people are spending their vouchers? So these are the information we can put in the model as a part of the input. So that's how, and then time is, so this is dynamic. So you put data in, you say this year you're going through a probability process whether you participate or not. And then if you participate, there is a weight change, and we record that weight change, right? And then we record for everybody, so the data is growing. At the beginning, you have the base data. At the next year, you have the base data together with what happened in this year, right? So if you go to an intervention, here's the weight. If you don't go to it, here's another weight. And then you keep this as your input for the year after and year after. So that's how you can build over time. And then because you have participated this year, that will impact the probability of next year. So these years are not independent. Instead of they are very, especially individuals, your behavior would be not jumping over. So there is that connection between years as well. So that's how this machinery is built, and then you let loose over time. The counterfactual part, the control, actually from the estimate of using chits over many years. So you have seen that trend earlier without, from 2001 to 2013. So that is basically the trend is built in as a regression model. Say this is how, if without intervention, where people should be. And then we use that as the counterfactual part. So that's the one part of the box, and the other part of the box has a lot of assumptions in terms of the effect, of these, in terms of all these, each of these is a parameter each parameter corresponding to assumption and put them together. Therefore, naturally, we come to the last one is the challenges that this model has lots of assumptions going in. And lots of assumptions means that you have to do a lot of research. You have to validate your assumption. You have to have some evidence that assumption is not too crazy. So that's the first part. Second part is our goal is to estimate multiple interventions happening at the same time. Which one is driving what, right? Is it the farmer's market that's most important so I can ditch community garden, or is the community garden really important so I can? So these are the natural questions that people doing evaluation want to be able to answer, but we don't have enough empirical evidence to say one way or the other. So we try to build them together, but we are not 100% confident that our assumptions are all being validated and the results are all great, right? So there is still a lot of research need to be done in this area. Also, model depends on the abstraction. So you try to mimic the real world, but you have to get rid of lots of noise. Am I getting rid too much and have the signal too weak, or I'm getting enough? So this is something that we need to have more empirical evidence, more research to be connected to actually validate the model. In other words, validating an agent-based model is a challenge itself. So that's about the modeling part. Do I want to do the conclusion part? Okay. Thank you for the assignment. So the conclusion part is that, first of all, the whole NEOP program is huge. It's been going on for a while. And I think LA County has done a great job trying to reduce obesity and other diet-related chronic conditions. And it's going to be ongoing for a while. In this evaluation process, we use the simulation approach, and the simulation results indicate that this program, if it's going on for a while, it would really work. So if you look at sorry, I want to go back to this chart. So if you look at this chart, at the beginning, the two are more attached to each other. You know, the intervention and non-intervention, they don't separate themselves immediately. In other words, the effect of these interventions don't take place right away. It takes time for them to take place. And that's an important conclusion, I think, as part of this evaluation. From our modeling point of view, we want to say that the agent-based model in this case is a very useful tool for synthesize information and then mimic the real process. All right, questions?
Hi, online folks and in-person folks. This is Gwen Driscoll. I'm going to moderate, and what I like to do is I like to take one question from online and then one from in the room and go on that way. So I'm going to start with the room. Does anyone in the room have a question? Then we have a number of questions, and one just clarification about the graph that you showed, Sue, the impact on obesity by 2040. Go back a bit. There was a difference. The viewers asking, was there a statistically significant difference?
This is simulated data. We definitely can do the significant test, but I don't think we did on simulated data, so we didn't feel comfortable doing that.
Anyone in the room? Yeah.
Sorry, thank you very much for this great presentation. I was just wondering in the same thing, but rather on the confidence interval. confidence interval?
We do. We have, because you run this over time, and we have it's a there are lots of random component there. So if you run it many times, you get confident. We did try that. Yeah.
Oh, okay.
It's too crowded to present that, I think. Yeah.
But again, there will be a big report with every detail you could want coming out in the coming weeks.
We didn't do the test per se, but provided that confidence interval just for illustrate.
Okay, I've got an online question. In terms of monitoring and evaluation results compared to the simulation results, if there is a difference in obesity prevalence between real world and simulated data, what interpretations would a person keep in mind?
So, all right, I just want to make sure I understand the question. If there's a difference between simulated results and real world results, what do people want to keep in mind?
That's a good question. So it's part of the validation process. For instance, we project for 2040, right? It's not happening yet, but you can definitely validate and retune, recalibrate your model from now. Let's say 2018, we have some new result. We have the short-term result as well, and we can compare the result from the simulation to the real thing, and then you can say, oh, I'm off by 10%, and then you can investigate where that off is, and then retune your model. The model can be, recalibrated easily.
Okay, I mean, and the follow-on to that question is, for example, year 2020 is 35% prevalence versus predicted prevalence of 40% for 2020. So.
Right, yeah, so I would agree with what Xiao said in that you would want to recalibrate your model once you have new actual data about how things look in the real world.
Thank you. Great presentation, and having sat in the early meetings, I know you guys have come a long way, so congratulate yourselves on that. I wonder, Xiao, if you could comment on maybe a little bit on the process of coming up with those parameter estimates. I think that might also answer the earlier question. I think when you have projections that are different from the real world, it's about understanding what those assumptions were, and trying to keep track of those assumptions is actually a lot more difficult than most of us would think it is, until you've done this sort of work, which we've all been doing in the past few years. Just trying to make sure we have all those assumptions and the parameter estimates not only in place, but that we can monitor and so that we can look at the changes. It's actually quite challenging. So
Right. So, what's his name? We actually learned so much from communicating with your group and observing you guys how these parameters are being recorded and being documented. So we have similar documentation as well, but I think our approach is more from outside and inside approach. Instead of built from the bottom up, we kind of top-down approach. In that way, I think we try to have the big parameters first, like for instance, over here. So what's the probability of going to intervention? And then that probability related to what? And then have all these bigger levels done first. Then we zoom in further. I agree with you. It's conceptually difficult to link these assumptions in a coherent way. Sometimes the assumption becomes kind of orphaned rather than an integrated part of the whole model. And we're still trying that part. Yeah.
Do you have a sense of percent of all of these assumptions, estimates, the parameter estimates you used came more from the literature, and what percent was more kind of you had conversations with close group that, or that we decided we're going to make assumptions about this and calculate probability, things like this.
We definitely have a document that says which one is from which literature, whether the literature is a random trial, or not, or it's coming from program data. We have a list of these are the assumptions. So that's why we have these sliders. At the beginning, these sliders usually are not assumption-based. Sliders are research-based. So these are how we distinguish them.
And I don't know off the top of my head what proportion. Do you have a guess, Christopher? Because you were looking at it most recently.
Yeah. Like all parameters, probably half.
That's what I was thinking too.
Yeah.
Yeah, I mean, so in terms of, just to sort of add to what Xiao said in response to your question today, each of these steps going from person to intervention and intervention to behavior and behavior to weight involves at least one parameter, sometimes more than one parameter. And so even though we start out with what looks like a relatively simple model of how these interventions might ultimately affect weight, it's actually really complicated. And because obesity is such a complicated issue, which is caused by so many different factors, and the causal models that you see of obesity are these huge models with like hundreds of arrows in them, and trying to come up with a model that can capture all of that is something I would never even want to try to attempt. This was plenty hard enough. And there just, for some of these paths, there just isn't any decent literature. And so you really have to go to the gray literature. You have to talk to people who work with these programs and try and get a sense of, what they think might be happening. And so that's why, knowing what all of the assumptions are and documenting what they are is really important, because as you learn more moving forward, you can revise those assumptions to be to fit better with actual observations on the ground.
So in other words, we'll see in 2040. Okay, we have time for one more question, but I want to assure everyone online and in the room that if you have questions that weren't answered, please email me, gdriscoll@ucla.edu, and I will make sure to hound the authors to get those answered. But let me end with this question. The simulation seems to assume linear growth in obesity rates. Is this realistic?
It's actually, we don't assume linear growth at all. So there is no assumption of linear growth. The weight change and all these things are actually nonlinear. So we don't assume that you go to intervention once, you're going to increase your walking 10 minutes, you go twice 20 minutes. It's impossible. So all things are actually nonlinear in the model. And that's one of the beauty of this simulation model. You can, mathematically, you can impose whatever you believe is a more realistic trajectory. So for instance, when we have a multiple intervention, the effect is not additive. You cannot say, I go to farmer's market, I'm going to lose 1 pound, and I also do community garden, so I'm going to lose 2 pounds. That's not real, right? So the active effect is actually the closer, so there is what we call ideal weight or ideal BMI. Once you get there, the change is not going to be that drastic. If you keep your weight really well, you're not going to lose a lot of weight down the road. So once you're closer to you get closer to your ideal situation, whether it's vegetable consumption or weight loss, the change will become smaller. So that's the built-in part.
All right, I want to thank both of our speakers, especially given that at least one of them is very sick, and thank everyone in the room and online for joining us. Please email me if you want slides or have further questions, and we will see you in January, on January 25th. Thanks.